All right, good evening, everybody, and welcome to the November edition of the online journal club with the Journal of Vascular Surgery. I say I already have a typo there that says October, but our hosts, we're very grateful, are from Cedars-Sinai, as well as from the University of Tennessee. And per usual, I will be pleased to introduce our authors as well as our presenters. The articles are from the Journal of Vascular Surgery, Outcomes of Symptomatic Penetrating Aortic Ulcer and Intramural Hematoma in the Endovascular Era, as well as the effect of Pulmonary Embolism Response Team on the management of outcomes of patients with acute pulmonary embolism, and that, of course, is from the Journal of Vascular Surgery, Venous and Lymphatic Disorders. Let me advance the slide here. And here are our hosts from Cedars-Sinai. We have Dr. Don Barrell, who's an associate professor of surgery there and within the Division of Vascular Surgery. And his trainee is second-year vascular surgery fellow, Dr. Lily Sadri. And from the University of Tennessee in Knoxville, we have Dr. Michael McNally, an associate professor of surgery and program director of their residency, and as well as Dr. Allison Johnson, who is a first-year vascular surgery fellow there. In addition, we're pleased to have authors of our papers, Nicole Russell, who is a medical student, as well as her mentor, Dr. Dennis Gable, who's the chief of vascular and endovascular surgery at Baylor in Plano, and is a professor of surgery at the TCU School of Medicine. And representing the other paper, Dr. Anahita Dua, who's an associate professor of surgery at the Massachusetts General Hospital. And last but not least, we have our special guest from the Journal of Vascular Surgery, who will be providing expert commentary, Dr. Akiko Tanaka, who's an assistant professor of cardiothoracic and vascular surgery at the McGovern Medical School, University of Texas in Houston, and Dr. Sherling Sai, an associate professor of surgery, UT Southwestern, and is chief of the Dallas VA Medical Center. Thank you both for being here. So, a couple rules of the road. Please stay muted. And as the faculty and trainees present, please put your questions and comments in the chat. From there, the moderator will pick up your questions and comments and may ask you to speak or otherwise pronounce your question. As you noted, this is being recorded for on-demand access. And please join us for the December edition of the Journal Club. That'll be on the 13th of next month, 6 p.m. Central Time, and hosted by Pittsburgh and Cooper Medical School. So I'm going to stop my share and ask Dr. Barrell to introduce his topic and subsequently his trainee. So thank you, Don.
Can everybody hear us okay?
Yes.
I'm going to stop share 1 second. All right. So let me know to make sure that everything's advancing okay.
Looks good, Don. Thank you.
Okay. So thanks to Paul and Misty for having us back. And we're excited tonight to be discussing this paper on the outcomes of symptomatic PAU and IMH in the endovascular era. So I think, as everybody knows, acute aortic syndrome is primarily thought of as aortic dissection, but also IMH and PAU. And all these have a often similar clinical presentation. And for the most part, we all treat these initially with medical therapy, primarily with impulse control. That being said, regarding dissection, we have a lot of data, ongoing randomized trials, et cetera, but much less data on the contemporary outcomes of IMH and PAU. So TVAR, we know, certainly has led to a paradigm shift in the treatment of thoracic aortic aneurysm, aortic dissection, on thoracic aortic injury. And as also we well know, TVAR has sort of an ongoing evolving role in the treatment of acute uncomplicated type B dissection. Certainly, I think everybody here has applied TVAR for the treatment of PAU and IMH, but we don't have as much data regarding those outcomes. So when you think about intervention for PAU and IMH, I sort of think it as type Bs, whether it be its step sibling, cousin, frenemy, or is this actually a precursor to dissection that we're just capturing at some point radiographically? All that being said, compared to dissection and on its own, are the risks of medical therapy greater? Are the risks of intervention greater when compared to dissection or to medical therapy alone? So I think when we think about that, the question is who to intervene upon, when to intervene upon these patients, and then why to intervene upon. Just like with dissection, are we trying to prevent long-term complications, or is there in fact a higher acute mortality or morbidity related to that? So this is a nice paper that adds some data to this. So from the MGH, and I won't go through all this because Lily's going to speak next on the details of this, but I think the short of this is that IMH and PAU probably have worse outcomes than we've sort of given them credit for, and maybe we should be being more aggressive about treating these in the acute or the subacute phase. So I'll hand things over to our second-year fellow, Lily Sadri.
No, it's okay. Thank you, everyone, for the opportunity to present. I have no disclosure. So acute aortic syndrome, as we went through, it's, as Dr. Burrell said, potentially related to aortic dissection, which has been very well discussed in the past couple of decades. The other flavors are PAU and IMH. And that's kind of what the paper, this journal club paper focuses on. There's not much data on the natural history and outcomes of this pathology, although we do see quite a few patients with this radiographic finding. And so TVAR, it's emerged as a very promising treatment for PAU and IMH in a refractory and symptomatic setting, meaning, patients with persistent pain and evolving radiographic features. And then the role of a prophylactic TVAR, though, in the setting of these findings is not super clear. And so the aim of this paper was to dissect that a little bit and to understand, to not only detail the rate of adverse events that happen with acute symptomatic IMH and PAU, but also to kind of determine how the natural history of these pathologies has changed in the advent of TVAR, and that was approved in 2005. So it was a retrospective single center review from 2005 to 2020. And the way the data was queried, radiology reports that contained the terms essentially that triggered PAU or IMH were determined. And then these were all independently verified by a vascular surgeon. And then a PAU was defined as an atherosclerotic ulcer that involved the aortic wall and allowed hematoma formation. So there was an ulcer that you can identify that created this hematoma within the media of the aorta, whereas an IMH is defined as the presence of blood within the media, but there was no overt intimal tear. And so those were the two kind of ways these two things were defined. Symptom status was confirmed with chart review, and it was defined as chest, back, or abdominal pain on initial presentation. And then recurrence was defined as the recurrence of this pain after being discharged from the hospital, but with complete resolution of the initial symptoms, but all of the recurrence had to have happened within 5 years. Asymptomatic patients were excluded, and then those associated with the aortic dissection were included, and those with an iatrogenic pathology, for instance, trauma. And then Stanford type A IMH and B IMH were included. So all patients were treated medically, and I have a little asterisk there because, as I said before, type A IMH was counted within this cohort, but the initial, like the kind of standard of care for treatment of a type A IMH was counted as initial operative ascending aortic repair, but it wasn't actually counted as an operation for this study group. But they were followed post-operatively from their cardiothoracic procedure because of the natural history of progression of the type A IMH for surveillance of the rest of the aorta. But the remainder of patients were treated with this high-intensity statin and impulse control, defined as blood pressure between 100 and 120 systolic and a heart rate of less than 60. The primary outcome was a composite one of recurrent symptoms, radiographic progression, intervention, rupture, or death from a related or unknown cause within 5 years of the initial diagnosis. And then the outcomes were recorded from the time of diagnosis to the end of the clinical follow-up. So the results, this is just an overview table of the demographics. Just kind of from a big picture standpoint, the cardiovascular comorbidities were prevalent and similar between all the cohorts studied. So the groups were divided between those with isolated PAU, isolated IMH, or IMH and PAU within the same patient. Asthma was more common in those with an isolated IMH. A history of DVT was more common in those with isolated PAU. And atrial fibrillation was more common in patients with in the combined group. And then when looking at anatomic variables, dividing patients up by PAU and by IMH. So for patients with the ulcers, 74% of them were in the descending thoracic aorta, and specifically most common location was in zone 4, followed by zone 3, then zone 5, and then zone 0, and last zone 9. The mean ulcer size was about 14 millimeters, and the mean ulcer depth was about 7.4 millimeters. And then 30% of this patient cohort had multiple PAUs throughout the course of their aorta. For the 62 patients with IMH, the IMH was in the ascending aorta in 39% of them, and then the remainder were kind of type B. And then 20 of the 24 patients with the ascending IMH, they underwent initial repair. But these, like I said before, these repairs were not counted as an outcome, but they were kind of tracked for long-term aortic events. And in general, one would think, given the type A IMH has a higher mortality in the immediate postoperative period, a kind of risk analysis was performed a competing risk analysis was performed to compare this patient group with to those that did not have a type A IMH, and there was no statistically significant difference in the composite outcome in the patients that had the type A IMH. But interestingly, the patients with an IMH and PAU combined, they did have a higher risk of the primary outcome compared with those that had an isolated IMH or an isolated PAU. And then when comparing isolated PAUs and isolated IMHs, they had similar long-term hazards of the primary outcome, which was that composite we mentioned before. So with regards to table 3, I actually think that this slide is very helpful. So the adverse outcomes are defined here as symptom recurrence, radiographic progression, surgery, rupture, and death. Interestingly, the follow-up time, it was mentioned in the paper, and we kind of know this from current guidelines or lack of guidelines, there's not really a good standard for follow-up. So it was really up to the discretion of the surgeons. But within the cohort that was followed of these 83 patients, symptom recurrence occurred in interventions for symptom recurrence occurred in the 24.1 patients and percent of patients. And this is really the TVAR. 17 of them got TVARs, one of them got an EVAR, one of them, one patient received a frozen elephant trunk, and one received a open repair. And outside of kind of this description, there's not too much else described about these patients, but it does give us a global understanding of the rate at which intervention was required. 27 patients, notably, so 32.5%, they died during the follow-up. 6 were from a related cause, 8 were from an unknown cause, and 13 were from other causes. The 6 patients that died from related causes, one of them had a stroke related to the progression of an ascending PAU to a dissection. There was pneumonia that was noted in a patient with a type A IMH that had a hemiarch repair and then had a pleural effusion. Pericardial tamponade related to a type A IMH that then became a dissection. There was a patient that had a stroke related to a progression of a type B IMH to a type B dissection. And then there was a stroke related to a type A IMH that progressed actually to a rupture. And then the patient declined surgery thereafter. And then there was an inoperable type A aortic dissection that originated from an untreated type B IMH. So overall, the incidence of the adverse outcomes at 30 days, there was a 26.5% kind of rate. There was a projected rate of 44.9% at 1 year, and then 57.5% at 5 years. And overall, the median clinical follow-up in this study was 1.89 years. So the discussion it's an interesting paper in that it talks about and really defines a subset of patients that there's not too much defined about, that have a serious pathology that we're now noticing more and more requires intervention. Symptomatic INH, PAU, or combined INH and PAU has a high rate of progression based on this paper with the need for intervention. Isolated PAU and isolated IMH are similar with regards to their hazards and primary outcome. And then symptomatic IMH with a PAU, so when patients have both together within their aorta, it's a significantly higher risk of the primary composite outcome compared to when they're isolated pathologies. So limitations and future directions, these are mentioned in the paper as well, but it's definitely, as with all studies, it's as with most studies, retrospective natures of the studies makes it a limitation. The anatomic characteristics of intervention were not fully described in this paper, and then the follow-up protocol, as I mentioned, kind of the who, what, when of each patient's follow-up CT scan, why they got the CT scans, when they got them, was not very well defined. But as we know, there's not much in terms of the guidelines. This is a conversation that's now starting to pick up the pace with regards to we should have guidelines, and then a selection bias, of course, which was also mentioned in the paper. So in conclusion, medical management alone may be, in some cases, inappropriate for these acute aortic syndromes. And this study suggests that an investigation into a more aggressive interventional strategy with TVAR is warranted. So thank you very much.
Thank you. So let me start off with a question and the things I want the authors to clarify. So I also see in the questions too, was there any size criteria on the patient who got re-intervention or the intervention? The 17 of them had a TVAR. Was there any specific criteria for the intervention for this patient?
Thank you. I appreciate your questions. I'm so sorry. I look like I'm a ghost or something in my car, so I apologize, but I am here. My name is Anaita. I'm one of the vascular surgeons from MGH. The primary author, Dr. Bellamo, who's one of our star vascular residents, is actually on a plane. Otherwise, she would be here. To answer your question, no, there was no criteria. As you know, with these patients, what ends up happening is kind of whoever's on call that night does what they want, and sometimes it's a logistics thing. Sometimes it's there's a vascular surgeon or CT surgeon that does every patient that's symptomatic in any way goes and gets a TVAR. Sometimes it's change in size. We do a CT scan and then a CT scan in 24 hours, 48 hours, and there's a difference in size. So they go. And so for this particular population, one of the things that was striking over the time period that we looked is that there was no rhyme or reason that was specific. Most of the patients, the symptomatology was pain, but there wasn't really much about an actual size that prompted people to go to the operating room.
Thank
It
you.
was really
And
just contour of the aorta, change in contour.
okay, also, I have a question about these patients are all symptomatic patient. And how did you decide the symptomatic PAU just to watch medically versus not? I think
So,
in the question will go to the time frame. How soon would you treat in your current practice?
I can speak to myself personally. So if I have a patient that is a symptomatic PAU, I would take them that day. I would take them urgently to the operating room and take care of it. My concern being that it would either expand or rupture. But I think that's part of the problem, how we define symptomatic. IMH is easy, but a PAU, if they just have just pain, and it may have been something that a previous CT scan showed, you have to believe that indeed this pain that they're having is coming from the PAU and that it's impending, something negative. And so that's what I would do. But the study goes over the course of many years. And obviously there are multiple surgeons that came through. And so I would say, just knowing anecdotally where I work, the likelihood is that if anyone actually believed that the PAU was causing the pain initially, they probably would have taken the patient urgently. And what probably happened is they maybe didn't attribute the pain to the PAU in the beginning. And then maybe 2, 3, 4 days later, with blood pressure control and this and that, they finally say, yeah, it is the PAU, and then take the patient. Obviously, if there's a change in diameter at all, that would prompt something. But I think the big thing is really attributing the symptoms to the actual disease, which is probably why you see that delay.
Thank you. And also, have a question about the IMH plus a PAU cohort. So, I feel a big difference between either IMH with the ulcer-like projection. Reading the manuscript, it looks like you included both the IMH with the ulcer-like projection on the imaging, and also with the PAU with some bleeding with a hematoma. And I think these two are very different. One is just a person who's maybe progressing to classic aortic dissection, which I wouldn't be too worried about unless the patient has a large aortic diameter. Versus PAU that's having a bleeding, I think it's a very dangerous patient. It concerns me for high risk feature for the rupture. Were you able to identify how many were actually the baseline was an IMH and versus an ulcer?
Honestly, no. We looked at all the CT scans, which is what kind of made this study special because it took so long to do. But we ended up going by what the radiologist ultimately called. And so that's how we classified them. But when we started to break it down into really, as you're saying, these subset categories, we didn't really have enough in any group to make good comparisons. So that's why it was lumped like that. But I completely agree with you that that would be a different pathology. And I think it just speaks to doing more studies in this group. If you look, even over the course of, years here, we were only looking at like 80 something patients. So it's just not that common. And I think that's part of the reason why we had to group it that way.
Okay. Thank you. There's a question from the participants. So question is, if a patient shows up with IMH or PAU and the decision is to treat medically, how many people would get repeat CT follow-up prior to discharge? For example, 3 to 4 days versus waiting in 4 to 6 weeks. I think it's
I
gonna
would
be
get it prior to discharge for sure. That's my practice. Prior to discharge, it wouldn't even be just prior to discharge. I would bring the patient in if I was admitting them, or I would have them get scanned probably 48 hours later. And then if it's depending on that, I mean, if it was not stable, then I might make a call. If it was stable, then I might wait until like the day before discharge. But they might even get more than one scan from me, depending on how long they were there.
okay. I totally agree. Okay. I'm looking at other comments. I think those are the questions we had, and I'm actually really surprised to see even in the endovascular area that you found a lot of death in these patients. And I guess we have to have a better surveillance protocol. As I see in your manuscript, unfortunately, the follow-up time was very short, which this kind of makes me think that no one's really following up those patients with PAU or the IMH. So hopefully we can find a better protocol for these patients.
Yeah. I think the real key with this disease process. So this paper was born of another manuscript that came out actually in circulation about asymptomatic PAU, and that's how we started. Because we had a slew of patients that were coming in again asymptomatic, where we were getting these calls from the medical team saying, "Hey, we found a PAU, and what do you do now? Do you scan it again? Do you bring them in? Do you clog your clinic? What do you do?" Of course, there are studies about the diameter, and like a certain diameter could prompt something, but even they're not great. So we ended up going through a slew of studies and essentially found that asymptomatic PAU is not a big deal. Then we thought, well, we've gone through all these studies. Wouldn't it be interesting to see? I mean, maybe in symptomatic, maybe we can narrow it down a little bit into what matters predictively. And that's what launched this study. And, I think what was pointed out earlier, and what you, of course, said too, that these are two different pathologies. The symptomatology really puts them in a different category. And we need to be, I think, relatively aggressive about intervening, especially with TVARs. I mean, nowadays, I won't say an easy fix. You can't ever say that as a vascular surgeon, but, versus what can happen to them, I think if you think about it, you should do it. And certainly with any contour change, IMH, I think you need to do something.
Thank you all. Anahita, I don't think you can see the chat, can you?
I can. I'm flipping back and forth.
If you have a chance, maybe run through some of the others' questions on the chat while we have Dr. McNally introduce the next topic, which will be the paper from the Venous and Lymphatic Disorders Journal. Thank you, guys. That was terrific. And I'm glad to see Misty finally got on.
I think my computer crashed and then we're having internet issues. It's a great day. So sorry I was a little late.
All right, Paul, can you see my screen?
Looks great. Thank you. Hear you loud and clear too.
Okay, great. First of all, I want to thank the organizers for the opportunity to present in Journal Club this evening. Tonight, I'll be introducing pulmonary embolism and the topic of pulmonary embolism response team. And this will be followed by our first-year vascular surgery fellow, Dr. Allison Johnson, who will be presenting the paper out of the Baylor Scott and White group in Texas regarding the effect, or titled "The Effect of Pulmonary Embolism Response Team on the Management and Outcome of Patients with Acute Pulmonary Embolism." Before I start, I want to congratulate the first author, Nicole Russell, who's a medical student, and she's joining us today. But that is a big deal as a medical student to have a first author publication. So congratulations.
Thank you.
So as far as introduction to the topic, venous thromboembolism encompasses approximately 900,000 cases per year in the U.S. And specifically for pulmonary embolism mortality, it accounts for about 100,000 deaths per year. It's the leading cause of death in women during pregnancy and the leading cause of death in people with cancer besides the cancer itself. As far as an economic impact, it's estimated that it's a cost of $15,000 to $20,000 per patient diagnosed with acute pulmonary embolism. It accounts for frequent hospital readmissions, which is published widely in the literature. And it's an estimated $10 billion cost per year to the U.S. healthcare system. So as far as pulmonary embolism treatment guidelines, the American College of Chest Physicians published their guidelines in 2021 as far as an update, actually a second update to their 9th edition guidelines. In this paper, it has treatment guidelines for all venous thromboembolism, and I've specifically added one here regarding the treatment for acute pulmonary embolism as far as two guidance statements. And one here is for acute pulmonary embolisms treated with thrombolytic agents with a suggestion for systemic thrombolytic therapy using peripheral vein over catheter-directed thrombolysis. This is listed as a weak recommendation with low-level evidence. And a second guidance statement for acute pulmonary embolism in patients presenting with hypotension with high-risk features such as high bleeding risk, failed systemic thrombolysis, or patients presenting in shock with high potential for death. The recommendation for catheter-assisted thrombus removal over no therapy. So that's just one example for updated guidelines here in the U.S. From U.S. publications. And this is also a secondary guideline published here that I wanted to feature was from the European Society of Cardiology, published in 2019. Again, a list of recommendations and a treatment with VTE, but unique to their guidelines, they have a specific recommendation for a multidisciplinary pulmonary embolism team. This was a class 2A, level C recommendation, but it's really for a PERT team in the management of high risk and intermediate risk acute pulmonary embolism management. So what is a PERT team? It's a multidisciplinary team specializing in rapid PE assessment, risk stratification, treatment, and outpatient follow-up. The overall goal is to decrease patient morbidity and mortality, and this was first described and implemented at the Massachusetts General Hospital in 2012. When looking at the value of a PERT team and discussed as far as outcomes and metrics in numerous publications, some of the metrics described was time to therapeutic anticoagulation, rates of major bleeding, hospital length of stay, catheter-directed interventions, and overall mortality. So here's an example of an acute pulmonary embolism treatment algorithm published in 2019 by the PERT Consortium. And really not to get into the details, but the first step in all acute PE management is the patient hemodynamically stable or not. And I'm not going to get into the details of the whole algorithm, but you can see the different pathways of treatment for low risk, intermediate risk, and high risk PE. But particularly this algorithm is really where is the consultation appropriate for a PERT team. And in this algorithm, it's for intermediate and high risk PEs per their publication. As far as the literature, there's really limited data regarding the impact of PERT teams, and specifically, it's really a majority of the studies are single institution. Here's an example of a single center study looking at 769 inpatients with acute PE, and they reported positive outcomes such as a reduction in 30-day inpatient mortality, lower rates of major bleeding, shorter time to therapeutic anticoagulation, and most dramatically, a reduction in mortality for the intermediate and high-risk PE patients, with a reduction from 10% down to 5.3%. Now, this article was really the highest level of literature I could find out there, and it was published in 2022, and it's a meta-analysis published on 26 studies, majority from the U.S., with a total of 9,823 patients included. A majority of these were patients with intermediate risk and high risk pulmonary embolism. Describes the composition of the different PERT teams, but really their outcomes were a greater use of advanced therapies in acute PE treatment, shorter inpatient hospital stay. However, there was no survival benefit found in this meta-analysis. I present this article before moving into Dr. Johnson's discussion of this paper as a potential discussion point after the paper presentation. So I want to thank you for your attention, and I'm going to turn it over. I'll stop sharing and turn it over to Dr. Johnson for the presentation of the article this evening.
All right, can everyone see my screen and hear me?
Yes.
So thank you so much for this opportunity to present here today. So as Dr. McNally mentioned, PE is a pretty significant burden in the US today. About a third of patients who are diagnosed with acute PE end up dying within 30 days of their diagnosis, and about a third have long-term complications. Thus, PERT has become increasingly important. Management has become increasingly complex with time, and this has included anticoagulation, systemic thrombolysis, catheter-directed intervention, or CDI, which includes thrombectomy with or without thrombolysis. Additional management options include ECMO and surgical embolectomy. The goals of the PERT team are to improve inpatient care and decrease long-term morbidity and mortality. Currently, there's no clear consensus on the management of those, particularly with intermediate risk PEs. Thus, the PERT consultation represents an important group to assess these patients. This particular study was a single institution retrospective cohort study performed between July of 2020 and April of 2022. Patients could be included via 3 primary pathways. And so that would be either from the ED with an acute pulmonary embolus, acute PE during a hospitalization for some other reason, and transfer from an outside hospital with acute PE. Patients were excluded if they were less than 18 years old. Their PE was identified to be subacute, their EMR was incomplete, or their diagnosis was not confirmed radiologically. The PERT team included 14 specialists, which were from vascular surgery, cardiothoracic surgery, cardiology, and pulmonology. Following evaluation by the PERT on-call team, the PERT members were invited to a conference call to help decide a treatment plan for each specific patient. The treatment options included anticoagulation, systemic thrombolysis, catheter-directed thrombolysis, surgical thrombectomy, ECMO, or IVC filter placement. And the interventions, if indicated, were performed by a PERT team member. The PERT activation also included, in addition to the in-hospital care, treatment and subsequent outpatient follow-up with a PERT team member. The endpoints in this study, so primarily was use of catheter-directed intervention, all-cause in-hospital mortality, and major bleeding event, which accounted for a hemoglobin drop of greater than 2 points, need for blood cell transfusion, or symptomatic bleeding. The secondary endpoints you can see here include mortality at 30 days and 12 months, ICU and hospital length of stay, vasopressor requirements, and in-hospital cardiac arrest. This study accumulated 279 patients with acute pulmonary embolus. Of these patients, just under 2/3 were considered to be medium risk, and the PERT activation in just under half of patients who are identified to have an acute pulmonary embolus during this study period. So in terms of the results, oh, excuse me, I have an automatic light. I'm sorry, that was my worst nightmare, and I confirmed everything right before, so my apologies. So this table demonstrates the baseline demographics, the comorbid illness and venous thromboembolism risk factors in the study cohort. The demographics between the 2 different groups were similar, including age, race, gender between the groups, and venous thromboembolus risk factors. Overall, in the study cohort, there were more males than females, and patients evaluated by the PERT were at increased likelihood of higher BMI and increased likelihood of having CHF, with a trend towards more medical comorbidities. Patients with current tobacco use, recent surgery, or hospitalization were less likely to have had a PERT activation. This table demonstrates the PE characteristics and severity for the entire cohort. Notably, patients who had saddle emboli or main pulmonary artery emboli were more likely to get a PERT activation than those who did not, and that was 75% versus 45%. Whereas those with segmental or subsegmental PEs were less likely to get a PERT consultation, and that was 17% versus 47%. In general, a larger percentage of the intermediate risk patients received a PERT consultation compared to those in the low and high risk groups. Those with PERT consultations were more likely to have elevated biomarkers, and this was particularly in the troponin and D-dimer laboratories. Increased PERT activation was also noted for those with either right ventricular strain or right ventricular dysfunction. This figure demonstrates the initial clinical presentation for those with PERT activation compared to those who did not have PERT activation. Those with PERT activation were more likely to have an associated DVT, to have the DVT that they have be symptomatic, or to have dyspnea when they presented. Additionally, those patients who had more vague symptoms on their presentation, including malaise or weakness and general fatigue, were less likely to have undergone a PERT consultation. Of the 279 patients that were included in the study cohort, 98% of those received systemic anticoagulation. 5% of patients in both the PERT activation group and the no activation group received systemic thrombolysis, and this was most frequent in the high-risk PE group. Patients with a PERT activation were significantly more likely to have undergone a catheter-directed intervention compared to those without a PERT activation. And additionally, those who had a PERT activation were significantly less likely to have undergone an IVC filter replacement. That was 1% compared to 5%. This figure demonstrates the target outcomes for those who did not receive a PERT activation compared to those who did. There was a decrease, but not statistically significant decrease in in-hospital mortality, 2 versus 5%, and decrease in 30-day mortality, so 2% versus 8%. For those who had undergone PERT activation, there was a similar 12-month mortality compared to those who had not, so 7 versus 8%. In-hospital mortalities occurred primarily in high-risk PEs with severity score of either 4 or 5. And about a third of the patients with in-hospital mortalities had been evaluated by the PERT team. About 2/3 of those in-house mortalities were transfers from outside hospitals, and just under half of the mortalities had associated PEARS. Additionally, something to be aware of, patients, a third of the patients who died in this cohort had COVID pneumonia, and this was believed to be contributory in the PE diagnosis. PERT activation was associated with significantly less vasopressor use and ICU length of stay by a half day, with similar median length of stay. There were several limitations in the study. So firstly, this is a retrospective EMR-based study, and the data is limited by accuracy and availability of data. Lack of long-term follow-up was also present, as I believe the follow-up was 12 months, and the study performed at a referral center with cardiovascular expertise, and thus the results may not be generalizable. Another consideration would be that the study primarily occurred during the COVID pandemic, and those with COVID have been previously identified to have very different or fewer classical risk factors for PE, higher D-dimer levels, and more ICU needs, with smaller vessels affected, and all of that may confound the need for admission, intervention, or PERT evaluation. So in conclusion, from this paper, the patients with PERT activation were more likely to have saddle and main pulmonary artery emboli, RV strain and dysfunction, or coexisting DVT, in addition to dyspnea during their presentation. From this paper, the authors have concluded that use of PERT was associated with an increased use of procedural intervention and improved outcomes, including reduced major bleeding, reduced in-hospital mortality, and reduced 30-day mortality. They also note that PERT team may improve quality of care in this patient population, but there are further studies needed to help elucidate the most effective ways to do this at varying institutions.
All right, thank you. And I want to congratulate Nicole again. I actually heard her give this talk at the Texas Vascular meeting last year. So congratulations to Nicole and Dr. Gable for getting the talk into a publications. That's really awesome. So one question from the chat, was COVID-19 associated with fewer PERT activations? And was this group less likely to undergo interventions?
First, yeah, thank you to Dr. Johnson for presenting that so well, and thank you to everyone else for your encouragement. But yeah, so 19% of the patients who were diagnosed with COVID-19 were only 19% of the patients who had COVID-19 were evaluated by PERT, and the patients who were evaluated by PERT and had COVID-19, they tended to have much higher risk PEs. And so we really had, I think there were only like 30 something patients who actually had a PE. So had a history of COVID. So we didn't really have a strong sample size to really be able to compare, between groups. But they did undergo less intervention, but it's just really hard to say if that's because they were treated because they were put into the PERT group, or if it was just because they had COVID-19 in the PE.
Or
so a lot of the patients that had COVID, many of them actually did not have interventions because they had a lot of other, as many of the COVID patients did, had a lot of things going on, and taking them for intervention at the time that this was going on. If I'm sure everybody remembers or doesn't want to remember COVID, we were trying to limit exposure as much as possible, and so the patients that did go for intervention were those that were terribly sick, but we thought would survive, because there were some, quite honestly, that we got consulted on that we didn't think were going to survive, or had a high risk for not surviving, even if we did something. And those patients, because of the pandemic at that time, were not intervened on. But the total was only 19 of the patients that were evaluated by PERT. So as Nicole said, unfortunately, we didn't have really a sample size that could answer the very question that you're asking.
Sure. I imagine these COVID-19 patients have so many other pulmonary issues too. It's hard to sort of figure out their complications secondary to the PE versus all of their other pulmonary issues. So one question I had was, it seems like the potential benefits of having the PERT system in place is, one, maybe a faster response time. Were you able to look at that? Was there a time difference, a difference in time in terms of like those who got interventions? Was the intervention faster in someone who had a PERT activation versus not?
So that was something that we initially wanted to look at, but unfortunately there was really not consistent documentation, and there was also a change in the electronic medical record, sort of earlier on. So we couldn't get that data. I do think that's really important, and other studies have shown that having PERT involved can increase time to anticoagulation or time to thrombectomy. But we were really limited, at least in our documentation. And so we have thought about that as an area for quality improvement. I think going forward, just thinking about how can we make PERT teams the most effective, I think that we need to have some performance metrics and knowing what things to keep track of and record. And I think that timing is one of them. And documenting in the chart, specifically that PERT is being activated and when, so that we can do more retrospective studies in the future.
Yeah. So as we go through the discussion of this paper, everybody should understand the reason that we did this is purely selfish reasons, and that our PERT program had only been started in 2017. And so what we were trying to do is show the value for PERT, because if you read the paper and look at it, there were a fair number of interventionalists that were not on the PERT team that did intervention on our PERT patients. And so I was trying to show value of the PERT team, and with the hypothesis that being a member of the PERT team having the clinical skill set that those members that are on the team have, that we may have better outcomes. And indeed, that was supported by the paper. But the goal of that was for us to be able to go back to our colleagues, and those that wanted to participate would be a member of the PERT team, and those that didn't, we would maybe perhaps limit their interventional abilities for patients that had PE, so that we could go then back and, in fact, as Nicole said, try to expedite or improve our time requirements. We tried to look at that. One of the things we had problems with is, unfortunately, our hospital system changed from centricity to Epic right in the middle of this cohort. So that's when she refers to difficulty with our system recording and data. That was one of the weaknesses of being able to get the data for this study.
All right. Another question about ECMO, for massive PE. Do you guys offer both ECMO and along with everything else, and how do you decide?
Yeah, so we do, part of our PERT team is CT surgery, and we consult, everybody once we get PERT activation, we'll consult with our cardiology colleagues, pulmonary colleagues, critical care, CT surgery, and vascular surgery. If someone presents in extremis or with significant issues with oxygenation, then yes, we will go ahead and offer them ECMO at that time. There are other patients that we feel that the decision's been made to go intervene on them, either with catheter-directed lysis or thrombectomy. We happen to favor mostly catheter-directed thrombectomy as opposed to lysis at this time. But we feel that there's a high risk that they may have more problems during the procedure until we get done. And sometimes we use ECMO on those patients as a bridge, but that is done in consultation with our CT surgery and critical care guys, and just get everybody's input so that we have that ahead of time. So the answer to the question is yes, we do offer those services. And our paper was actually followed up by a second paper, a sister paper, that talks about our use of ECMO in patients with PE.
Great. And then one last question from me. So one of the benefits, it looks like, from this PERT team is the multidisciplinary approach, that the patient, after PERT activation, gets put into this multidisciplinary sort of group. Although there was no difference in the 12-month mortality, can you figure out how many of these people actually get followed up in like pulmonary hypertension clinic? Because that's one thing that if you just get, treated for the PE, you might not necessarily get plugged into the follow-up. Do you have that data, or are you going to look at that?
So we are going to look at that, and we are gathering that data. Part of our PERT team development was we have a pulmonary hypertension clinic already established, and part of our development was entering every single patient. I don't think we have 100% as in most studies, but everybody has a follow-up scheduled with pulmonary hypertension clinic prior to discharge from the hospital, in addition to follow-up with their treating interventionalist. So we are in the process of gathering that and hoping to provide, we provided 12-month data, but we're hoping to provide 5-year data over the course of the next 12 or 14 months.
Great. Well, thank you. I'm just going to keep everything on time. There are no other questions in the chat. Thank you very much.
Well, that was a great discussion, and that's quite an undertaking to try and get 5-year data. Paul, thank you for
My pleasure, Misty. You're muted. Yeah.
Of course I am. This whole day in technology could not get any worse. So what I said was, thank you, Paul, for keeping everything going while I was having so many technical difficulties. Dennis, that was a great kind of undertaking that you're going to do to get 5-year data. That's a lot of work. So we'll look forward to seeing that. But thank you for joining us for the November version of the JVS Online Journal Club. December is coming. It'll be coming on December 13th will be our next journal club. Paul mentioned that in the previous slides. And thank you all and have a great night.
Have a nice Thanksgiving too.
Oh,
Chad.
yes. Happy Thanksgiving.
Thank you.
Thank
Okay.
you.
Thanks, y'all.